So as we were discussing, the ideal trabeculectomy or the perfect trabeculectomy is like a perfect marriage. I don't know whether there is anything really like that. But to get a good trabeculectomy would be a good idea. So we start with the preoperative surgery preparations, and some of the drugs which we are using in patients we need to probably stop. Whether to stop pilocarpine and prostaglandin analogs, there is a little bit of a debate. You may or may not, but definitely anticoagulants, antiplatelet drugs, it's better to stop because we don't want blood there. Anesthesia, all types of anesthesia, including peribulbar, local, just at the site of the bleb, topical and subtenons, all have been used by different people. Personally, I prefer a peribulbar. The site of exposure, the technique we had been using earlier was a superior rectus, but because that produces a lot of hematomas there and promotes scarring exactly where you don't want it, so we have avoided it and use a 8-0 vicryl through pure peripheral cornea, or don't use a suture at all if you get good exposure. The conjunctiva is the very important tissue when you do a trabeculectomy, and handling that well is extremely important. So you can do the flap with limbus based or a phonics based, each having their own plus and minus points which I have put, but I have to go a bit fast for 7 minutes. So the technique which I generally prefer is a limbus based flap, and for that I go around 8 to 10 millimeters posterior and cut the tenons and the conjunctiva and the tenons separately, and tenons cut is made deep enough so that I can get a clear subtenon space, and that controls the amount of blood you lose and the amount of cautery you need to do. So minimum cautery is definitely advisable. The other option is to do a phonics based flap, and in those cases where I do this, I prefer to leave a little bit of a frill of conjunctiva at the limbus, which helps in watertight closure later on, which I will show later in the talk. Very important to dissect posteriorly because you want posterior flow. That's the ideal trabeculectomy. It has to be flowing posterior. Using antimetabolites, though some people don't use in all cases and only in high-risk cases where there is higher risk of scarring, I use in all cases. Antimetabolites I prefer to use is mitomycin C in a concentration of 0.2 milligram per ml, though you can use up to 0.4 milligram per ml. The exposure time can vary from 1 to 4 minutes. I prefer 2 minutes, and of late we are using preoperative subconjunctival, actually subtenons injection of mitomycin about 2 minutes prior to starting. 5-fluorouracil was used earlier and in similar timings, but nowadays we are not preferring that. Whether to use pledgets dipped in the drug after dissecting the conjunctival flap, and sometimes after dissecting the superficial scleral flap and put it at the plane to reduce the scarring, intrascleral scarring. The trabeculectomy superficial flap is the one that's going to control your filtration, and it has to be a very standardized shape, and all surgeons would have their preferences. My preference is a rectangular flap of 4 by 3 millimeters with the internal ostium being covered on both sides by at least 1 millimeter of the superficial flap to control the amount of flow that is there. So location of the flap, we prefer the superior hidden by the upper lid, and if possible try to go a little nasal, leaving the temporal side untouched so that you can do future surgeries there. Inferior flaps or inferior trabs are extremely avoidable and almost never done. The superficial scleral flap dissection, you want very clean edges and single plane dissection, and I prefer to do this with a crescent blade. Some people prefer to use a 15 number blade, but with a crescent blade we are able to achieve better single plane dissections and in a lesser time. So my preference is to use a crescent blade. It controls the size also very nicely. The internal ostium is the ostium which is extremely important, and the option is there to use a punch or use a manual with Vanna scissors, but you have to get very clean cut edges, confirm that you have actually penetrated, and do an iridectomy, and before you close, check that there is free flow of fluid by injecting through the side port. My preference is to use a punch. The final IOP you are going to get depends on the aqueous flow dynamics of the wound construction and suturing. This is modified later by scarring. So you have to achieve proper closure. So my preference is to set the filtration pressure by taking 2 sutures and with temporary knots and not able to. With temporary knots, then inject the saline from the side port and check the egress of fluid. And once I am satisfied that the egress of fluid is not causing a shallow chamber or not leaving the eye very tense, I convert these knots to full knot and then bury the knots. After that, take a releasable suture in most cases. In some cases we don't, but in most cases so that you can control the flow. So this is the temporary knot. Then we inject the saline from the side port incision and you can see the blood being washed out. So that's the flow which is coming out. And I check digitally whether I am satisfied with the end pressure and only then convert the knots to complete, take 2 more knots and turn them to the scleral side. After that, the releasable suture is taken, and the releasable suture you pass through the clear cornea first, and then from the base of the flap, you come out and take a suture at the edge of the superficial flap. It has to be tied with a throw of 4 knots so that it remains releasable. And after you have tied the suture, pull the end which is outside and make sure that the loop is shrinking and the knot is actually releasable. So you can see there I am pulling the thread and making sure that the knot is actually releasable. So these are the graphic pictures of the knot, and you can see here that you will have the suture which is buried, the end is buried into clear cornea. All you have to do is just pick it up and pull it out. Watertight closure of the conjunctiva is preferable, and this can be achieved both in the fornix base flap as well as the limbus base flap. I prefer to use 80 round body needle vicryl, and when it is the fornix base flap, 2 wing sutures on the side and a running suture in the middle to achieve watertight closure. Whereas when we have a fornix base flap, close the tenons separately with a running suture and the conjunctiva separately with another running suture and achieve the bleb elevation on table itself. Post-operatively, standard treatment of steroids, antibiotics, and cycloplegics, and you can manipulate your trabs after the surgery is done by digital massage, laser suturolysis, post-operative antimetabolite injections, needlings as you require, which is beyond my talk, and achieve the ideal trabeculectomy with a posterior flow and not much of avascular conjunctiva. Thank you.